first of all, thank you for your flexibility this morning. Sometimes these things happen. I was teaching ClinCore when I got the text. So it looks like Mr. Weber found out what the situation was. You guys got a schedule. We don't. But good kudos to your class leader in reaching out and kind of finagling that. That way the time wasn't wasted. I do apologize. But I am tracking, I think, the new schedule now where I'll see you guys again until Friday morning. Is that accurate what you guys are tracking? Think so? There's been no test on Friday? Yeah. It's exciting. You don't sound excited about it. Oh, yeah, it is. Oh. Okay. All right. So we're going to do lecture 3. If you don't have it already ready to go during this lecture, please try to download lecture 4. The odds are we'll get through this one and start on that one because those are a little bit bigger, and so it'll take a little bit of time so we can get a head start kind of on that. Any questions from when we last met, which I'm sure feels like 3 months ago, even though it was like a week and a half? Yeah, you guys aren't even looking at my stuff yet. Okay. Well, when you start looking at it, please let me know if you have any questions. And we're going to jump into some last set of intro stuff, okay? Again, a picture's worth 1,000 words, right? This, depending where you end up working, could be some of the stuff that you end up seeing and stuff that's going to require radiological imaging. Regular Friday in Texas is very possible, yeah, especially with all the construction they're doing, right? So, this is on here because when this person comes in, you're likely to do something called an EFAST or ultrasound, which we'll briefly talk about in this lecture, because that's specifically for trauma type stuff. So, where do you start when these patients arrive in ED? Well, I just kind of spoiled the line there. EFAST, but other stuff too, right? Stuff we're going to talk about in other, a little bit in the lectures here, but then more in block 2 as well. Like you're going to do, this patient basically is going to get what we call pan scan. It's a generalized term, right? They're going to get the EFAST ultrasound very likely. If they're stable, they're going to get a head CT and a neck CT. You're also going to end up getting a chest x-ray, right? You're also going to end up getting probably abdominal x-ray and then likely multiple MSK x-rays depending on what the injury pattern is. So where do you start with? Everything, right? They're going to get everything. The nice part about it, when you get through all your training here and you go through your senior semester and you learn how to use that ultrasound and that EFAST, is you can order all that stuff, and then you all can do the EFAST while you're waiting for that other stuff to take place. So you can get some information immediately. And you'll get a lot of that hands-on training in senior semester when you start doing that. I think the seniors just did their test on it, actually. It's one of the few hands-on exams you guys have in this program here. And here's why you get these x-rays. Now, I know, again, we haven't gone over and really started reading them a whole lot yet, so I will point some of this out for you for those that don't know. So what we got here is a pneumothorax on this side, okay? And you will get better at this. Don't worry about memorizing this part for this block. We're going to hit this hard in block 2, but you can see where that lining of the lung is and how it goes along the shape of the thorax, and there's black in between the lung and the ribs. What is black on x-ray typically? Air. There's air where it's not supposed to be. Now the question is, why isn't all this black if there's air in the lungs? Because there's a bunch of tissue there, right? There's alveoli, there's bronchioles, there's all that stuff that's going to kind of give you that whitish gray. This is showing you that there is no lung tissue, it's just straight up air and ribs. And then we go over here on the pelvis, right? Fracture, fracture, fracture. Over on this side, right? This is just down in here without going through the whole pelvis, which we'll do later, right? But these things kind of jump out, and this is why we get the x-rays. We don't just go to CT. So just some examples, some of the abnormalities that you'll be starting to pull out, especially if you're working in the emergency room, and urgent care, if you get a chest x-ray or something like that, you'll be the first ones to look at these things well before the radiologist does, right? So you'll already have an idea of what interventions need to take place once you learn those interventions in urology going forward in upper class, as you do in senior semester. And I said this about 12 times, so it's very important already. The patient must be stable-ish before they go to CT, because patients die in the CT scanner. If they're not stable, stabilize them first, then send them to CT. Watch those vitals. All right, so here's kind of what we're going to cover. We're going to talk about ultrasound. We're going to talk about nuclear medicine a little bit. We're briefly gonna kind of discuss a newer modality there towards the end with the brain, and how to order studies, okay? We've been kind of already doing that throughout the few lectures of how to order the studies, what do you put in, don't you put foot pain, right? 22-year-old male comes in with right foot pain over third metatarsal from dropping 5-pound weight. Fantastic. Now the radiologist can at least paint the picture and knows where to look to try to help you kind of find the abnormality. So we'll talk about some of that too. All right, so ultrasound. Here's the vocabulary you need to know, right, when we're talking shop. Transducer, you guys had, they still do the ultrasound lecture freshman semester, right? Where you get like that brief introduction, they take it away? Okay. So they used to give that, which is fine, because it was kind of like redundant to do it here and do it there, so I just kind of know where you're at. So they officially stopped that. Great. So the transducer is the device, and we're going to see some pictures of it here in a little bit. It's a device you use to get the imaging. That's what that's called, all right? There's multiple different kinds. You don't have to get hung up over the linear and the curvilinear or the different types of probes here for this class. That'll come in handy in EMED when you're doing your EFAST a little bit, just the basics. But for this class, you don't got to memorize what types of probes do what. I'm going to show it to you so you know, but I'm not going to test you on that, okay? But the other words are important, right? So echogenicity, that's basically, an ultrasound uses sound waves, right? So think of a bat in a cave. They're practically blind, they can't see, they use echolocation to figure out where they're at. This is what an ultrasound does. The transducer pushes sound waves, okay, into the body, and that reflects off back to the transducer, and different areas of the body, whether it's bone, whether it's an organ, fluid, whatever the case may be, has different levels of echogenicity and different levels of reflection, and that's what kind of pushes off back into the transducer so you see the image. So when you compare things to each other, much like we have radiolucent and radioopaque, right, for x-rays and CTs, we have the same concept of ultrasound, but now it's hyperechoic or hypoechoic. Okay, and we'll look at the differences between those things. So the hyperechoic is going to be brighter compared to surrounding tissues. Hypoechoic is going to be darker compared to the surrounding tissues, given the prefix on the words. Okay? Posterior acoustic shadowing and posterior acoustic enhancement, I'm going to save that until we get to the slides that show it. That's a lot easier to understand when you look at it on a picture as opposed to just trying to memorize the definition. So we'll get to that here in just a second. That's everything we're going to cover. What do we have here?
Twins.
We have twins. We have more than just twins. What does this look like? All right, so you got baby one, baby two, baby one, baby two. There's two uteri there. This is an abnormality, like this can't happen. This is an anatomical anomaly. There are women out there who have two uterus, or uteri is what they would call it. And yes, they can both end up having a baby at the same time. So these are twins. But here's the septum between the two uteri. All right? So this is a patient with two uteri that is pregnant in both of them. What's a really interesting patient is when you get one of these that there's two different dads. That is physically possible, right? You look it up. I think there's some cases about that somewhere out there. But that's not a problem you got to deal with. That's a social worker problem. But no, but yes, this can absolutely happen. You can have women who have two uteri and end up getting pregnant in both of them. All right, so again, FYI, I'm not going to quiz you on history or anything like that. But really, what from the gist of this slide, where's my Navy folks? Any Navy folks in here? Yeah, one. You heard this last semester. Thank you for ultrasound. So one good thing the Navy gave us, right? Ultrasound. No, so really, it was in the 1940s when the Navy, not only has the Navy been using it for years, decades, right, with their sonar and their ships to be able to see where they're going and use it for submarines and all that stuff. They were the ones who actually started using it in abdominal imaging in the 1940s. They were the ones that come up with, hey, we use this on a regular basis for our normal job every day. We think this could actually have some medical implications. Let's start looking into that and researching it. So for all intents and purposes, the Navy basically invented the medical use of ultrasound. They were the ones that started doing that. Physics improved in the late 40s. In the 50s it got better, and then we were actually, the imaging got better, and once imaging got better, we were actually able to correlate it clinically to different diagnoses and conditions. We got our Doppler in the 60s, and then the 3D imaging that everybody gets when they're pregnant, they want their 3D, you know, their baby and everything, that you can thank Japan for that. They started that in the 80s. It's a fun toy. It does nothing medically at all, which means for all you who are wearing the uniform and serving, TRICARE doesn't cover it if it's on an outside facility. So if your facility in the MTF does it, that's okay, right? So when you get your pregnant, I want the 3D image of the baby. If we offer it, you can get it. Otherwise, you're paying out of pocket for it. It's not cheap. So, all right. So here are your transducers. Look at the 7 different kinds. Each of these sees something a little bit better than the others, right? I don't need you to worry about that. Just know that when you get into like EMED, they're going to talk about certain ones that you're going to use. You're mostly going to use the curvilinear and the linear probes, which are the first 2. That's most of what you're going to use. Your ultrasound techs who are actually trained to do most of the other studies will use a lot of the other ones. Here's your gel. So in radiology, right, in x-rays, when somebody is of larger girth, we'll say, right, we need to add more radiation to get a better image. Ultrasound, it's all about the gel, right? If you think that you don't have enough, or you're getting a bad image, then just go back to the old SNL skit. Just replace cowbell with gel, and you'll never forget. And eventually, and I'm probably getting close, this is going to outdate a lot of you in this room. But I see a few laughs still. If you've never watched this skit before, please Google SNL cowbell. Christopher Walken. It is worth the 2 minutes of your life. It really is. But anyways, gel is big. So when you are doing this stuff, you're like, God, the images isn't really working out. It looks like it's the right depth, which you'll learn in senior semester. Just add more of the gel. Here's what it creates. Okay. So the one on the far left, I think we already got that figured out, right? Not an alien, baby. And what does a baby sit in, right? The uterus, but then also what's it surrounded by? Amniotic fluid, right? So it's something about the amniotic fluid. And so that's what's all around baby here. So again, different than x-ray. X-ray, air is black. Ultrasound, fluid is black. Don't get that confused. And you can see that here by looking around the amniotic fluid that is around baby. That is all black. This is artifact here. We'll talk about that later. That's not fluid. There's not like this magical fluid spike sitting through the child. What's the middle picture? Heart. That's the heart, right? Now I have it nicely labeled for you. But what do you notice with the labeling? It's upside down. Anybody have any idea why it's upside down? From the mouth, that's a good guess. So it's actually the way we do the heart, it's called a subxiphoid view, to where you're actually shooting up underneath the xiphoid process in the sternum. So what ends up happening is the ventricles, this is the top, the ventricles are closer to your transducer because you come from the inferior area and shoot upwards. And the atria are farther away from your transducer. So that's why it looks like it's upside down, because the transducer is sitting here and it's shooting the ultrasound or sound waves into here and it's reflecting back. So that's why the ventricles look like that. It's just the angle that we're doing it at. But what do we notice? What is in all of the chambers? Blood, fluid, which is why it's black, because it's full of fluid, not full of air. Nice part about these is you can actually see the pericardium around it. You can watch the valves kind of work and see if they're working well when you're having like the live ultrasound views. And then what we got on the far right, it's kind of liver, it's kind of labeled. It's also liver and labeled. Yeah, so what? I don't know, right? This is definitely an abnormal study. And once you start to see more liver ultrasound pictures and things like that, you'll recognize that that's abnormal and it shouldn't be that way. We've already seen some CTs, how at least should all be kind of the same density, right? The liver tissue. I got a bunch of some kind of cysts in this area here, definitely, because they're all black on the inside. So these are definitely fluid-filled cysts. And then when we get down here, I don't know if they're cysts, if they're other kinds of lesions. It's not pure black. And then here I got this big, I think it's a pancreatic mass. It's just really close to the liver too. So these are things that are abnormal, is what we call them, right? I don't know what they are because ultrasound doesn't do a good enough job to tell me for sure yes, this is cancer, or this is a benign lesion, or what the case may be. But it's enough for us to know that further studies need to get done. Okay? I'm not going to make you read a lot of ultrasounds because 90% of ultrasounds you order are being done by the ultrasound department outside of EFAST. When we get to those you will be expected to be able to look at and know what's normal or abnormal, but we'll look at some of those pictures. Typical how ultrasound works video on YouTube. I don't have sound here, so it's pointless for me to do it, but it's there for you guys to do at your leisure. All right, so a little bit of physics behind it, right? So the acoustic energy, so the sender and the receiver, that's the transducer, all right? It pushes the sound waves out, it hits the object, which is usually a body part or a mass or something along those lines, and then it reflects the waves back. These are all sound waves. This is not radiation. This is 100% safe in all walks of life, all humans, right? Pregnant, kids, all of that. This does not harm anyone because it is just sound waves, all right? So the things that are more dense are going to reflect back. And they're going to be more hyperechoic. The things that are less dense are going to reflect back and be more hypoechoic, okay? And here's what some of the things look like. So now here's a side view again of your left ventricle, your left atrium. This is a side view. Here's your aorta down here. So the aorta is down here. Left atrium, left ventricle. But you can start to see the pericardium here is a little bit more dense than the inside of the heart. So that's why you get the brighter white. What you have here is going to be skin on this one here and the different layers. So you got your epidermis up here, epidermis, your sub-Q fat, your muscle, and the cortex of the bone. Now we're not going to use ultrasound very much for bone, but what you will use ultrasound potentially for in your clinics is if there's a cyst or some kind of lesion here in the subcutaneous tissue that you want to go in and drain at some point, this is where this would be easy for you to go and find it and kind of pinpoint it. You can use musculoskeletal ultrasound just really for that epidermis, dermis, subcutaneous tissue area. You can tell by looking at this cortex of the bone here, right? How well defined is that compared to the muscle versus an x-ray? It's not. Not going to see a fracture that often with this. Can you see one? If it was big enough, yeah, you could. Usually it's incidental finding because we're not going to use ultrasound for something like that. All right. So here is a picture of a cyst on ultrasound. So this cyst is not supposed to be there. What I want you to focus on is look at just behind the cyst, how it's more hyperechoic than it is around it. Everybody see that? That's your posterior acoustic enhancement. So the reason that is like that is, I told you, we have the sound waves going through the body, and then we have a section of fluid here. The fluid's not very dense. It doesn't really reflect any of those sound waves. That's why it's black like that. It just goes right through. Which means I have an abundance of sound wave energy going straight through the cyst and hitting this area just behind it, now all reflecting back, creating that extra enhancement. Whereas around it, all the sound waves are getting slowed down by all this extra tissue, so it's not as bright as right behind the cyst. This is another tool you can use to know and go, oh, that's going to be a fluid-filled cyst because I have that posterior acoustic enhancement. Okay? Does that make sense? I show you this because we're going to get to another picture here next, or later on. It's going to have like ribs in the way, and ribs will show up as like just a giant black shadow because they can't see anything, and that's going to create something else. So this is the posterior acoustic enhancement. That's how you know this black area is full of fluid. That's just another tool for you to use. Now, I'm going to show you the other thing, the posterior acoustic shadowing. What we have here is a gallbladder ultrasound. I have the red arrow is a big old gallstone. okay? Gallbladder is usually filled with sludge or bile or something like that. Sometimes nothing, depending how much is in there, right? Because it stores it and it'll kind of squeeze it into the intestines. So depending on the time frame, there might not be this nice, beautiful, dark area in the gallbladder if it's not full of bile, right? But I have a big gallstone. So the gallstone is more dense than all the surrounding tissue inside the gallbladder. So because of that, the majority of the sound waves are already reflecting up, causing a little bit of hyperechoicness right there on the gallstone, which means now I have less sound waves right behind it. Why I have posterior acoustic shadowing now. Because I've run out of energy. The sound waves have bounced back. There's nothing there to give me any information. Whereas the surrounding tissue still has some of those sound waves, so it's brighter than just behind the gallstone. Alright, so go back, look at this posterior acoustic enhancement, understand the physics behind that, and then the shadowing and the physics behind that. This can get a little tricky, so if you have questions, let me know. Come up on the break, or if you want to ask it now and kind of explain a little bit further, right?
Is that like,
Yes.
can you compare it to like a flashlight being where there's an object and the shadow behind it?
So the easiest way to compare it, I guess, so it's tough to do it with a flashlight, right? Because what does a flashlight not do? A flashlight doesn't reflect back rays, right? So I don't want to compare it to a flashlight or the sun, because there's some reflection there, but it's not reflecting back to a receiver, right? So, because even if I did like the sunlight and kind of did a bottle of water going through maybe water instead of the human body, right? So the human body works well because it creates a shadow on the sidewalk. That's more of an X-ray analogy though, because of the way that it projects the shadow. So the best thing I can say is, again, going back to that bat analogy, right? When it's flying through the cage and it puts out its echolocation, if all the stuff bounces back at it, it knows there's a rock there, which means it can't see anything behind the rock because the rock reflected all of that sound back to it. So it has no idea what's behind it, right? Whereas if it's flying and it does something, it puts out the echolocation and it gets bounced back from around, but nothing from here, it knows I got stuff here, but I have somewhere to still go through, kind of like in this area. I still have room to go because it went through some fluid or some air. Does that hopefully makes it a little bit better? What's your question? Go for it.
I was curious, so you said that the fluid on these shows up as black.
Correct.
What happens if you had an air pocket? What would that look like?
So an air pocket just obscures everything, right? Air and ultrasound are not friends. Sound waves do not go through air very well, right? It's kind of like, again, another analogy of that would be if you think about how well sound goes through air, it's actually really poor, right? Which is why the sound carries the best wear in really cold, dry climates where you don't have a whole lot of air molecules around, which is why, like, if you're like up in northern Alaska or northern Canada in the dead of winter, you can whisper and hear it like really far away. It's because there's not, the air molecules are spread apart because of how cold it is, how dry it is. They're not compact and condensed like normal air is here in Texas right now with the humidity. Like, it doesn't travel well. So because sound doesn't travel through air well on an ultrasound, it doesn't do you any good. Which is why if you ever get, anybody ever had an ultrasound done for their gallbladder or liver? No? If you do, it's like fasting, don't eat anything, because we don't want any air in your bowel, air in your gut obstructing the view of trying to see the gallbladder and the liver. So they don't go well. So there's not really like a, oh hey, this is air on ultrasound, except for in one situation, which I'll show you. Yeah. We good on these two things? Yeah.
So behind the cyst is hyperechoic?
Hyperechoic, yes. Hyperechoic, correct. Now, that's in relationship to what we're talking about, right? I can very easily, and I don't want to confuse you, but I want you to understand kind of how we're describing it. Because we're talking about the shadowing of the enhancement, that's correct. But I could very easily turn around and say, this gallstone is hyperechoic when compared to the surrounding area. I could say that the cyst, the fluid in the cyst, is hypoechoic compared to the surrounding area, right? It's like with X-ray, the radiopaque and the radiolucent, in comparison to what, right? Something else on the image. So if I were to give you a question like this, right, and I wanted to have you pick out between hyperechoic, hypoechoic, or whatever, I would have to give you in relationship to, right? Something of you know, the cyst would be described as what in relation to the rest of the image or whatever. And you have your choice of hypoechoic, hyper, radiolucent, radiopaque, stuff like that, right? So you are correct, but it is in relationship to the main object we're looking at. Does that make sense? Okay. So, don't worry about this. The crystals are the one that reads the sound waves. We don't get into the physics on there. It's for some of you who want to do that. We just covered this. Cystic ultrasounds. Cystic structures appear black on ultrasound. Calcified structures, gallstones, things like that are going to appear white. And then usually you get a shadow that's formed. Okay. This is an important chart. Start this chart. The reason this is an important chart is because you guys will be using an ultrasound machine. Okay? There are multiple modes on an ultrasound machine. If you're in the wrong mode, you won't be able to really see that well what you're looking for. So when you can't see what you're looking for, one of the first steps is double check your mode and make sure you're on the right mode. Okay? So this is an important chart, definitely start this. So A mode, for the most part, eyes, ophthalmology. And that is, we won't learn about that here in the EFAS, but you will learn that senior semester, and that is part of the practice you're going to get. You guys are going to get to ultrasound each other's eyes. So it's pretty cool, actually. B mode or Bravo mode, this is the most often one used. So when we're doing the gallbladder, when we're doing the liver, when they're doing the growth scans for pregnancy, they're just using the standard B mode. Okay? That's going to be most of your soft tissues. M mode is when we're looking at things that are moving, primarily the heart and the lungs. You're going to learn how to read an ultrasound under M mode for pneumothorax. So you'll be able to look at this and tell me if there's a pneumothorax or not, based off of just a singular image I'll give you. We're going to learn how to go over that. But in order to get that image, you have to be in the M mode, which is motion mode. And then again, the heart with the valves and the ventricle and the atrium moving, you want to be in the M mode. If you're in the B mode, it's going to be really blurry. You're not really going to be able to make out what the heck's going on. So you've got to be in that mode. Doppler we'll talk about. Doppler is specifically looking for blood flow. And we will discuss what studies we do that in, testicular, ovarian, things along those lines. You'll see what that looks like, and we'll talk about that as well. That's when we know if there's blood flow anywhere. And then the duplex is going to be like your DVT studies, deep vein thrombosis, any other type of vascular studies that we're trying to look at structure and flow. Doppler and duplex are usually used in conjunction with one another when we're looking at vascular stuff, right? But when we're doing like testicles and ovaries, which we'll talk about, duplex is not utilized. It's just Doppler because there's no major vessels for us to evaluate in those organs. But know what mode to use for what you're trying to evaluate. Here's a couple of pictures of what Doppler looks like. So here's your Doppler, right? Do not let this fool you. We'll talk about it more when we get to the testicles and we start looking at some of those images. Red is not arteries, blue is not veins. Everything we've always learned in all of our textbooks of A&P is all the arteries are red and all the veins are blue. Okay? Know your blood is not blue before you cut yourself open. Like, it's not a thing. But this is designed for red is blood flow towards your transducer. Blue is blood flow away from your transducer. That's what these colors mean. I don't really care that much as long as I can see both. Right? I see reds and blues, that means I have blood flow to and from, that means those vessels are open and blood flow is happening the way it's supposed to. Okay? So but do not just look at it and go, oh, okay, you got good artery flow and the venous flow, maybe not so much. Red and blue don't do that on Doppler. Okay? B mode right here. Take a look at the B mode, it's all labeled for you so you can kind of see. So we got the splenic vein on there, the celiac trunk, the superior mesenteric artery, the aorta. We can see all of those, right? So it's really good for looking at the vasculature and kind of seeing where things are at. It doesn't tell me blood flow, but do I really need to know blood flow in the aorta? Not really, right? There's blood flowing through the aorta. It's not going to be a to and from, right? That's why that's more used for areas that have a lot of arteries and veins to make sure that the organ is well perfused. That's what the Doppler is used for. Whereas if I'm trying to evaluate different anatomy parts, I can use my V mode. And again, this also works for gallbladders, livers, things along those lines. M mode up here. Okay. So this M mode up here. Let me take a look. This is, yeah. So that is an area of a pneumothorax, or the lung sliding. We'll talk about what that looks like later. But what this is the image up top, right? This is the image you're taking. And then when you flip it to M mode, it takes this one line that is tracking the motion and it spreads it out over a period, almost kind of like an EKG, so you can actually see the lines and kind of what it looks like in this one little area of where the line's at, which is in between two ribs and checking out the lung pleura. And we will look at that in more detail of what a normal is and what an abnormal is. And then down here we have a duplex study. So this is looking for a DVT area. It's showing you how they're using the Doppler along with the duplex. You don't have to, but you can. Just know that duplex is checking those vessels for clots and things like that. And then the Doppler is going to be more for the blood flow and perfusion of the organ. Really, if you know this chart, you'll be fine for any questions that I may ask, right? As far as ultrasound images go, you'll likely be EFAS stuff, but these are where some of the questions will come from. Another Doppler and quantitative flow. This kind of tells you what I just said as far as towards transducer, away from transducer, which means if I move the transducer to a different spot in the body, these colors could swap, so that's why it's not that big a deal. You're looking for perfusion. I see it going both ways. All right, so overall ultrasound, what are the pros of this, right? Well, first of all, we can get static and motion images. You guys have been seeing just static images. We talked about motion. You can get that as well with it. X-ray is kind of hard to get motion images, right? Same thing with CT, but ultrasound can give it to us. Super inexpensive, very mobile, and no radiation. No radiation. Cons? I haven't found one yet. So if you do, you let me know. I guess the only con would be ordering one when it's not the right thing to order, because it's not going to get you that answer, right? So if you know when to order it and you order it correctly, then there really are no cons of this thing. Blue, right? Studies of choice. When do we want to use this? For sure, any pelvic organ studies. Radiation is never the answer for pelvic organ studies. Now, a pelvic organ is not the pelvis. That's a bone, right? Pelvic organs are the organs within the pelvic region. The uterus, the ovaries, the testicles, okay? So that's when you're going to be using ultrasound on male or female. Pediatric studies. Some pediatric studies, if it's an option, and we'll go over which ones those are, right, through the lectures, it can be an option over X-ray. Sometimes it's not, right? But you will be told which of those studies is, hey, if it's a kid, you're not doing radiation until you do the ultrasound first. Superficial lesion, we talked about the skin, the cyst, you can use it for that, for drainage and being able to see it. Non-invasive vascular studies, so looking for that blood flow and those blood clots. Pregnancy monitoring, right? Image guiding sometimes. We won't cover that too much in this, but you can use it for image guiding procedures. Like I said, draining cyst. You can watch your needle go in to make sure you're in the right area before you start pulling fluid out. Cholecystitis. Inflammation of the gallbladder. Gallbladder study, that's what that is. So, cholecystitis. That is the gallbladder inflammation. That is the study of choice. Evaluates that gallbladder really, really well, looks for stones, looks for any issues. And on top of that, you guys are learning the Murphy's test, right? You're doing ultrasound in the right upper quadrant, you're doing your own Murphy's test, right? Or they are. So it's good information to have too, because if it hurts them, well, you've already just done it right there with the ultrasound. And then the fast exam trauma assessment, which we will cover later on. Patient positioning, I don't care. Sitting, lying, standing, for the most part, they could be in a wheelchair, they could be anywhere, because you have that transducer, and you can move that transducer into any position and stand anywhere around the patient that you need to, so it's not a factor. So patient mobility and position is not a factor with ultrasound. There is a contrast that goes along with ultrasound. It is very rarely used, but it would be wrong of me to talk about contrast in all the other modalities and not at least mention the ultrasound one. Micro bubbles, right, is the contrast. So this is where air comes into play a little bit. Now, how do I know that's air and not fluid? Fluid is black in ultrasound. How do I know that's air and not fluid? You're going to hate me when I answer it. Because I introduced it. I gave them the micro bubble contrast. I did it intentionally because I wanted to do it, right? So basically it's like a small injectable gas, okay, super, super small, like it looks big on here, but these bubbles are smaller than a singular red blood cell. This is magnified, okay? So are you ever gonna order one of these studies? Probably not. This is more of a specialist type study that they're gonna order to try to visualize where does blood flow go, is there an issue with it, where is the air going? It's super, super, super small. But again, it would be wrong of me to tell you all these other contrasts, not tell you that ultrasound does have one, okay? It's the microbubbles. It's covering the benefits, these are for your review, right? No radiation, cheap, simple, get you some good information, static and motion images. Uses we just covered. Questions on ultrasound. Quick, down dirty foundation, right? To introduce you to it for when we get to some of those pictures so you have an idea of kind of how they're being created. All right. Nuclear medicine. This is another one that I don't need you to read the images very much. I need you to know when it's appropriate to order, okay, and what we use it for. So, here's the difference between, first of all, alpha. What kind of imaging is that? Good. CT. What kind of slice? Oh, from 3 months ago, right? Axial. That is an axial CT slice. Okay? What's Bravo? What kind of imaging is that? Nuclear medicine. What's the difference? Anybody know? Colors. There's colors. Look at the colors on the CT. There's colors. Good job. Okay, we're going to go over what the difference is. It's the same type of scanner. The nuclear medicine scanner, it's a CT, PET CT is what it's called. Positron emission technology, I think is what it's called, is what it stands for. But it's a PET CT. It's the same type of scanner that has special receptors so that when you give certain radioactive pharmaceuticals, it can get that read. Okay? Here's your vocabulary. I'm not testing you on nuclear medicine vocabulary. So, it says down the bottom, reference only. Reference only. We're going to talk about it briefly, not testing you on it. I care more that you know when to order it and what it looks like on the pictures. So where did it come from, right? Well, first we need the medical radionuclides in the 40s and the 50s. But in reality, they started using it in the 60s, trying to provide the first blood flow maps of the brain. Okay, and then we realized that, boy, we can start to see the organs if we know exactly what to give it. And then using that technology to get to the imaging. Ultimately, what they had to figure out is every body part, intratumoral and endo, needs a different type of radionuclide for this to work. And they had to figure out what do we attach the radiation to, the radioactive, nuclei to, in order to get that body part to absorb it. Which is why there's such a stepwise gap. We're like, oh, let's kind of look for blood flow in the brain, but just the brain. And they're like, oh, we might be able to do other organs. Okay, well, we should really create a better machine to look at all this stuff. So it kind of stepwise, goes through that into where we're at today. This is what the machine looks like. It's almost just like the CT scanner, guys. The difference is these extra guys on the outside. Mainly this guy up here. All right? So here's the images that it produces. So the concept behind it, so we can check it for cardiac efficiency. That's what these little donuts and half circles are. This is a cardiac scan. All right. This is a whole body PET scan. So checking for cancers or inflammation of certain joints and things along those lines. You can also see it in black and white. So you can see what's called a ventilation perfusion scan of the lungs. We can do it for all inflamed joints, so like rheumatological disorders sometimes. And then it's a good functional scan for the gallbladder in that aspect. So these are just some of the examples. We'll talk about the ones that I need you to know about. Here's your nuclear medicine thing, okay? We just talked about this, that there's different radionuclides for different bodies. So what happens is they take the radionuclide and they attach it to something. So like for the brain, we'll say like a sugar molecule. Okay, because the brain loves glucose. So they want to do a brain scan. They attach the radioactive nuclide to the glucose molecule to create a radiopharmaceutical. They inject the patient with the radiopharmaceutical and let them sit there for a little while to let it go through the body and let those organs absorb it, and then they scan them. And then the areas that have absorbed that radiopharmaceutical light up like a Christmas tree. And that's where the colors are coming from. It's coming from those extra sensors on that machine that a CT doesn't have, but a PET CT does, that's looking for the body giving off radiation, right? It's a CT scanner basically, so all patients have to be lying down. So there is still some limitations to that if they're not able to lie down. This is what I just talked about, kind of how it does it. Right? Attach it to that. Now we have this. The cell goes, ooh, I like the compound, not necessarily the radiation, but the thing you attach it to, and the cell absorbs it, and then now the cell has that radiation. You don't need to know this. You'll need to know some of it for endo, and they talk about certain things, but this just goes to show you the radionuclides, all the different ones, depending on what I'm looking for. So if I were to use the TI-201, and I'm looking for thyroid issues, guess what's not going to go up like a Christmas tree? My thyroid. But it's great for cardiac perfusion, right? So this will be something that when you get into some of those other ologies, you're like, oh yeah, I remember that I-131 that was on that nuclear medicine slide. Because that will come up for thyroid stuff, right? So here's how it attaches to tumors. We have learned, and that's why these things come from different things, the thyroid tumors, the IN-111, different tumors. We have learned what certain tumors like. So we are able to attach that radionuclide to the compound that tumors like, that the tumor cells will take up, and that's how we highlight the cancers in that aspect. People are way smarter than me. I don't know how they figured this out, but they did. And this is why we use nuclear medicine primarily for what we call, or what is called PET CT scans, but for metastases, right? You have a patient who has a prostate cancer or colon cancer, and they're trying to see, are there metastases anywhere else in the body? You get one of these. You get what's called a PET scan, which is basically a whole body CT, inject the material, sit around for a while, and they put you under the scanner and see what lights up like a Christmas tree. And this is how they find those lung mets, or those brain mets, or those bone mets, before they even start showing up on any other imaging. Best thing about nuclear medicine is it's a really good functional tool, right? Everything is based off of activity. Cardiac perfusion, right? How active is the thyroid? Cancer cells are very active. It's more of a functional assessment than it is an anatomic assessment. We're not using this to find fractures. We're not using this to find masses. This is when we found the mass, and we're trying to figure out what it is and what's going on, right? We can biopsy it, or we can do these nuclear medicine studies. We know you have a large thyroid. I feel the nodules. We'll learn this next semester. I sent you for a fine needle aspiration. They're like, doesn't look benign. We're not sure. Nuclear medicine study. Let's try to confirm that and see what's going on. Okay? The biggest con, the patient is the source of radiation. Yes, we're going to give them radiation by doing the CT scan as well, but they're the source of radiation, which means once I inject him with this pharmaceutical and he gets his scan done and he leaves and goes home, he's still emitting radiation for a short period of time. Now these half-lives are pretty short in the aspect where it's not like he's going to be emitting it for weeks, but that's an important counseling fact of, hey, after you get this scan done, if you have any small babies or infants around, right, I would refrain from trying to hold them for at least the next day or so until your body flushes out the radiopharmaceutical, right? It's an important patient counseling technique. There's your four main uses, which we already kind of talked about: the thyroid, the brain, bone, and cancer. Major drawback in nuclear medicine, that's the gist of nuclear medicine, guys. It's not super in-depth, mainly because it just needs you to know what it is and what it can be used for. Major drawback is the patient's source of radiation. Major benefit, it's functional, so we can see how things are working. Different variations right here. And now we're going to go through and see what they look like. So when you recognize it, you kind of know what's going on. Here's your bone scan. Metastatic disease. I want to draw your attention to the right tip fib as opposed to the left. right? A lot of these things are gonna be bilateral, so you can compare one to the other, the affected side to the non-affected side. What do you think is going on there without reading the slide? Stress fracture. How would I know if this is stress fracture versus a possible metastatic cancer? Patient history. Have they recently been diagnosed with a cancer? If not, stress fracture. Did you order this because they were coming in with this leg pain the whole time and like the x-ray was negative and yada yada, like stress fracture? If they just had their prostate removed and they're getting a scan done, possible mets, right? Patient history, super, super important. Now, full disclosure, right? Yes, this is a stress fracture. Yes, nuclear medicine can see that. MRI is still your study of choice for stress fracture if you're gonna go there, right? It's cheaper than this, okay? You can get it done a lot sooner than this can. You don't have to make the patient the source of radiation when we have magnets, which is non-radiation, to be able to get that answer. So if somebody asks you what's the study of choice to confirm a stress fracture or diagnose a stress fracture, the answer is MRI, right? Sidestep into clinic. You're almost never going to order an MRI for stress fractures because the treatment is just rest to get better. You don't need an MRI to confirm that. But if there was a question about what's the study of choice for stress fractures, it's going to be an MRI. But these are what the bone scans look like, okay? And you can check for metastatic disease or stress fractures on these guys. Yes, on the bottom. I put that on there. Unlike everything else we said, which is why I want you to stick with what we talked about before, because I'm not going to really give you a nuclear medicine study and make you decide right from left. Just by the nature of what they determine the protocols are, I said everything was opposite as if you were looking, right? My right is the patient's left, my left is the patient's right, whenever I'm doing x-rays or CTs. Well, hang on a second. That's not what this slide says. Nuclear medicine is different. Bone scans are going to be this way. Don't get hung up on it for the exam because I'm not going to give you this and expect you to know right from left, right? I just want you to know that when you get out there for nuclear medicine studies, if that throws you off, it shouldn't. They should label it well. Nuclear medicine studies, for whatever reason, they just decided we're going to flip it the right way. I don't know why. I don't have an answer for it. As somebody else wants, I have. Just how it is. So, but the thing is nuclear medicine should always be labeled like this. Whereas your CT scans won't be labeled, right? These things should always be labeled. So, here's your myocardial perfusion study. Right? So what we're checking here is how well is the cardiac muscle being perfused. So it's absorbing up that area of the muscle and the oxygen, the blood from the heart beating, and you're trying to watch for that. So the question is, well, is this normal or abnormal? What do you think? So the answer is normal. And I'm going to show you why in a second, right? These are just different views of the heart from different angles. There are two ways to perform this stress test, right? Pharmacologically or exercise. Most of the time we do exercise because that's the easiest way to get the heart rate up. But there are many patients in a wheelchair who can't do it, right? Can't get on a treadmill, can't do the exercise stress test. So there are drugs that can be given to make the heart rate go faster to create basically a pharmacological stress test on the heart. Here's your normal and abnormal. And here's the view, right? So you got your short axis, your horizontal axis, and your long axis. But look at how bright red and colorful all three of those axes are. And now look at the abnormal below it. And how it's like faded. And it's not the pretty little circle or the pretty U shape or backward C shape, right? It should be one fluid throughout the whole area from start to finish, bright reddish, orangish kind of circle or C or U or whatever direction it's in. But when you come down here, these are areas that are not being perfused, which means the blood flow is coming in and it's not perfusing the heart the way that it should. So this would be an abnormal study on the bottom. HIDA scans. Okay? So we already talked about how ultrasound can check the right upper quadrant area, right? That's just gonna check for gallstones. It doesn't tell us how well something's working. But this can tell us how well the bile ducts and the gallbladder are working, and that's the HIDA scan. So we can inject it with it, and then we can watch and they can take pictures of the liver and the bile ducts, the gallbladder, the common bile duct. You don't need to memorize the anatomy here, right? But when do you use this? I think you have cholecystitis. You got an inflamed gallbladder, I think it's angry, it's ticking you off. I ordered the ultrasound, and for whatever reason they ate, or so there was air in the way, or whatever the case was, the ultrasound was not equivocal, right? It couldn't tell me yes or no. It's kind of like the radiologist like, I really don't know, can't really tell, couldn't see the gallbladder, that kind of thing. Well, if the cholecystitis is bad enough, what are we going to do? We're going to remove the gallbladder. So we need to make sure that it's the gallbladder. So that's where you would order this HIDA scan to go, I think you have cholecystitis. Ultrasound didn't tell me what I needed to know, so now we're going to go to this. Also, if somebody had their gallbladder removed, you do one of these, look for any biliary leaks afterwards. Okay? Wonderful thing about this is it's super sensitive. If this thing is negative, there's no cholecystitis. Like it is negative. But these things take hours to perform, which is why it's not the initial study that we do. That's why the ultrasound is. It's a lot faster, and most of the time it'll get us that answer. All right. Let's take 10 there, come back to the top of the hour, we'll finish up nuclear medicine. We're almost done with this slideshow. We're almost done. Alright, so some good questions on the break, right? So just remember to functional scan nuclear medicine, functional scan, HIDA scan, ultrasound if you're just trying to evaluate for the gallbladder. Keep the questions coming on the posterior acoustic shadowing and enhancement if it's confusing for you. I'll try to find a way to kind of describe it to make it a little bit more easier to grasp, because it is abstract, right? A lot of this stuff is abstract, and especially since I'm giving you a bunch of basics and we haven't even put it to use, right? It'll hopefully come into play more as we get into those later slideshows. Okay, another nuclear medicine study, the VQ scan, or the ventilation perfusion scan, okay? Now, initially, right, initial test for people that were concerned about pulmonary emboli or clots in the lungs is a chest x-ray. Am I going to see clots in the lungs from a chest x-ray? Probably not. There are one or two findings that you could see, which we'll talk about in block 2, but it's like less than 2% of patients, so we're going to talk about it so you know it. So if it comes up on the pants, you know what those word association things are, right? But you're not really going to see them. But we still order the x-ray because what if it's not a PE? What if it's something else and we completely missed that, right? CT pulmonary angiography is your primary study of choice for a PE, but what if you don't have a CT scanner? Or more importantly, because most PET scanners for nuclear medicine are CT scanners, what if you can't give the patient contrast? What if they're pregnant? What if they have an allergy to the contrast? Now what do? I do a ventilation perfusion scan, a VQ scan. Yes, and we'll talk about this more in block 2 when we get to the PE algorithm of why can I give a pregnant patient this, even though technically it's some radiation for a PE as opposed to the CT scan. I recognize that fact. So for right now, what I want you to do is put in your head that this would be for somebody who's allergic to the contrast. I can't give the contrast. What am I going to do? A ventilation perfusion scan. So the normal scan is right there labeled normal scan, much like the cardiac scan, right? Dark instead of colored, but it's showing uptake. I'm putting it in, the lung tissue is absorbing that. In my abnormal over here, I have chunks where the black arrows are that are missing compared to my normal. Those are areas of decreased perfusion. That signifies that I have a pulmonary embolism somewhere. Now, it's not as nice as the CT. I can't scan through and figure out in what vessel and where is it at, but I can at least know whether or not they have a PE. And by the time you guys are looking at these things, that means you will know what you need to do with that patient, right? As far as treatment goes, follow-up or admit or send home or whatever the case may be, depending on other factors. So this is something that we can use when a CTPA is contraindicated, primarily, usually allergic to the contrast. Okay? It's really the only time we go to this one, because the CT is so much better and much more specific and can tell me exactly how big and where that pulmonary embolism is. So that's what we're gonna do as a study of choice, but what happens when they can't have contrast? Here's the thyroid scans. We're gonna go over this in more detail in endo, so that'll be the last time you see these things, right? So A is normal. Doesn't seem like there's a whole lot of uptake there. The thyroid isn't a super active gland, right? It does a lot of good stuff for us, but it's not super active, and that's why the normal is kind of just like this lightly shaded scan when we do this, I can never say it, this scintigraphy, right? Graves' disease is basically hyperthyroidism, or a symptom of that, and you can see now how active that is compared to the normal one. I'm not going to make you read these on my exam. I need you to know that thyroid scintigraphy is the functional test from nuclear medicine to test for thyroid issues. Right? So we're covering these scans. I need you to know the highest scan is the functional test for the gallbladder and the biliary tree. Okay? I need you to know the ventilation perfusion scan would be the functional test if you can't do the CTPA for pulmonary embolism. But what I do want you to take away from this is the opposite of what our brains tell us, especially. When you get a thyroid scan, okay, you have hot nodules and cold nodules. It's the opposite of what you would think and everything else we've talked about with nuclear medicine. Hot nodules are usually benign. So the one here on the bottom that shows this darkened area of uptake compared to the rest of the thyroid, probably a benign nodule most of the time. They're still going to do a biopsy and all that other kind of stuff and make sure. But the cold nodules, much higher incidence of malignancies. Right? If for some reason you get the scintigraphy afterwards and you're like, I'm not really sure, you're still going to order the FNA, but I will tell you, nobody's going to slap your hand if you see a hot nodule and you go, you know what, it's probably benign, let's just monitor it and see what's going on. You will get in big trouble if you do not order a fine needle aspiration on a cold nodule on one of these scans, because the majority of them are thyroid cancer, which is opposite from the intuitiveness of what what our brain says when we're learning. Oh, it's hot, that means it's bad. Not in thyroid's case. Questions on that? Functionality test of the thyroid. Thyroid scintigraphy. Okay. How do we just evaluate a thyroid just to see if it's enlarged? Is there any issues? Ultrasound. But if I want to know if it's functional, I need the nuclear medicine equivalent, which is the scintigraphy. This is that positron emission tomography. That's what it was, technology. Gosh, come on. This is really what's designed to look for those metastases. We already kind of covered that. Oncology PET scans make up 90% of the use of this. You guys typically won't order them. Oncology will, right? But your patients are going to be getting a lot of these. Why is this important? Why do you need to know this? Well, if you got somebody coming in, you want to order a CT on them, and there's another opportunity to order something else that maybe isn't as much radiation. If they're getting a lot of PET scans because they're in remission and they're making sure, if you can not give them a CT and there's another way to evaluate something, that'd probably be ideal, because these folks usually get scans sometimes monthly. It just really depends. I had a classmate who sat in these chairs with me that ended up not completing the program because during phase 1 got diagnosed with stage 4 colon cancer, had to step aside, came back and actually restarted again, like went into remission, restarted, and then it started metastasizing. At one point he was getting PET scans, I think, like every 3 weeks. So just think about the CTs and how much radiation and stuff like that. He passed away about 4 or 5 years ago, but it's scary stuff. Get your colonoscopies. Okay, don't hold off on those. But anyways, just to show you, like, they can be pretty frequent on these things. So you be really vigilant on those patients and their radiation absorption. But PET scans are for meds. This here is FYI, you don't really need to know this. They're just now starting to get into this, and I think it's super cool and interesting. And by the time you guys are out there practicing stuff, this may be regular course. It's not quite yet. Right now it's still specialized in very specialized neurological clinics. But they are now using nuclear medicine to perform single photon, the SPECT scan, to check for brain abnormalities. And looking for different lesions that are like super, super small. It's really cool. It's in its infancy, right? But this may be something by the time you guys are going through phase 2 and out there practicing that is starting to gain a lot of traction. You may start seeing some of this stuff. All right, now if you have your slideshow up, you know this is now a slew of blue slides. So just a quick kind of covering. I don't care about the coronal transverse sagittal type thing for the VQ scan. This is just reminding you that ventilation perfusion is for that lung scan. If you're concerned about a PE and they can't have the contrast. Rest and that stress. How do I know this is a normal thing? Well, because it's not, because I'm stressing them and it should look the same. All right? And this is why we do the stress test. Because if I just gave the cardiac perfusion scan and just scanned them without stressing them, this looks normal. But once they start going to work and that heart starts beating faster, it's not perfusing like it should. So that's why the stress test is so important. And remember, there are pharmacological options if your patient is wheelchair bound or bed bound in order to do these studies. They should look the same on both. Yeah. A normal study would be same or extremely similar, right? We just went over all the studies for nuclear medicine scan. Which one is this? This is the bone scan or bone scintigraphy. Yeah, there it is, the bone scan, right? Bone lesions or occult fractures. Which one for lung function and perfusion? EQ. Which one for the thyroid? Thyroid scintigraphy. Liver, gallbladder, common bile duct. HIDA. Hepato. That big word. 4 letters. HIDA scan. Which one for the cardiac? Myocardial perfusion study. Right? And that's the myocardial perfusion study. What is it? The heart muscle myocardium perfusion study. What color are cystic structures on ultrasound? Black, because they're full of what? Fluid. Which means if I have a blood vessel, it's going to be what color on the inside? Black, because blood is a fluid. Good. Calcified structures appear what? White, and because they're so dense, what's behind them? The posterior acoustic shadowing. Benefits, it's not radiation mobile, we covered that already. Uses of ultrasound. Good, pelvic organs, that's one of the most important ones. EFAS, good, we're going to cover that later. Pregnancy, good. Yep, we can do it for a thyroid as well, right? Yep. Yep. Non-invasive vascular studies, good. Say it again. Aspiration? Oh, sorry, you said aspiration, and I was thinking like when somebody's drinking a barium and they aspirate into their lungs. Yes, if you're going to use it for procedures to drain a cyst or something and aspirate the fluid out of that, yes. See, words and meaning can mean many different things. It's important to clarify. Good. All right. Major drawback in nuke bed. The patient is radioactive. All right. The patient is the source. The major benefit, it assesses what? Functionality. And we just covered all that. Questions on group 3 or lecture 3, whatever you want to call it. Okay. We're going to move on. Once I figure out, there we go. All right. If you forget where the bones are, just use this slide. It will tell you everything. Okay, so now we're going to get into the MSK stuff. Some of this is going to be review as far as your stepwise process. That's because we talked about it how long ago, right? And now we're going to start implementing these things. We're going to start reading these x-rays. We're going to start looking at it. We're going to start seeing what some of these conditions look like and how they look different than normal, okay? This is where we take those 3 lectures of really thick material that we just covered, we start putting it to use. Do not stress if at first look, you're just like, what is going on? I go slow, I'll take my time, ask questions, I will go over it again and again if we need to, because I know it's abstract, but we're going to get through this and you guys are going to be okay. What are we looking at here? Good, that's your trabecular bone, right, or your medullary bone. Does it look healthy or not healthy? Right? You're not gonna see a picture of this X-ray. It's really just to kind of prove a point on something. What if I said to compare it to this? Now it looks healthy, doesn't it? Why do I do that? Because until you know normal, you may not be able to pull out abnormal. So don't beat yourselves over the head if you're not seeing these fractures, these abnormalities in the first time you see the image. Right? You gotta look at it over and over again. This is normal trabecular padding. This is somebody with osteoporosis. It's like an electron microscope type version of it. But alright. So what are we gonna go over? The ordering studies, how do we read the images, and then we're gonna start talking about the stuff. We will not get through this whole slideshow today, I do not expect to. So we'll pick it up on Friday and probably finish it on Friday. So, and if not, then that's okay too. We'll still get through it all. Because when we start getting down to this lower extremity lecture, so I'll tell you guys now, we start getting through like the last lecture, it goes a lot faster because we've already covered and belabored how to read the X-rays. So now you guys, by that point, you guys are noticing the fractures, and now it's just knowing what to name them because some of them have certain names depending on what part of the body they are. So, ordering studies, right? We talked about it already, but the S-bar format. Recommendation, it's more of a recommendation of what you want them to evaluate. So the way I end all of my radiology requests is please evaluate for any abnormalities. I just leave it at any abnormalities, right? I don't want to say please evaluate for fracture. Now they're supposed to look at more than just fracture, right? But I don't want to limit them to just that. So I just say please eval for any abnormalities, thank you. So blank year old this was the injury, this is where they hurt. I'm concerned about this, please eval for any abnormalities. Patient provider contact info, more your contact info, don't just put pain. The more you give, the better read you're going to get, the less of a chance you're going to have to call the radiologist and find a professional way to tell them that you found a fracture that they missed. Right? And I had to do it multiple times, and we'll talk about how to do that professionally a little bit later. Because there's a way to do it. What's your approach? The very first thing we do, every single time, right patient, right body part. Now, for this exam, you don't have to worry about that because you don't have a patient in front of you. But when you are in clinic, right patient and right body part. Do not read don't read his x-ray for her and give her his results and vice versa. That's bad. All right? Next you're going to go, is this the right view or what view am I looking at? So you know how to associate yourself anatomically. Then you're going to go through your systematic approach, which we're going to cover again. Use the same approach every time. I'm showing you my approach. I don't care what your approach is, as long as it's the same approach for you every single time, and it encompasses every category of stuff. That's what's most important. You'll describe what you see kind of in your mind's eye, and then if you see something, note it, and keep going through your approach. Don't stop. Even if you're like, I'm pretty sure your forearm's fractured, and you get the x-ray, and there's the forearm fracture. Great. Don't stop there. Look at everything else. There might be other injuries you miss because you got excited by the shiny new toy that showed up on the x-ray, right? So here's the same slide we had all the way back in the first lecture, right? This is my process. Correct patient, correct image. We're just going to assume we're doing that every time. All right? And make sure you don't forget that. Then I go through the cortex, and I look at that thicker outer cortex bone, nice and bright white. When I see something like right here, or right here, that looks like that might be an abnormality. I can't really tell. I don't know if it's a fracture or not. It kind of looks funky because it has that jagged, but it's not a clear, dark line. That's why we use two of them. Then I'm going to note that and go, okay, I'm going to move on and come back to it later. I check everything. I go over every carpal, every metacarpal. Every single area on this image is your responsibility as a provider. After the cortex, I go through the medullary texture. Now I'm looking for two things through that medullary texture between the bones. One, is the density equal throughout? Does it look like it should through all the rest? Two, if I see a fracture in the cortex, or even if not, do I see a dark black line in that medullary texture? You can, particularly in peds, get a fracture in the medullary bone, but not have it actually broken in the cortex. It can happen, especially in peds, because kids are bendy. kids will do lots of things to where like their bones won't break like on the outside, but there'll be an issue on the inside. After I go through the medullary texture and I'm looking sure to make sure it's the same density, then I go to my joint alignment, and this is where your anatomy really comes into play. Knowing where the bones are supposed to sit in relationship to one another, right? Knowing that, is that a normal gap over here? Or is it abnormal? It's normal on this one. But what is that gap supposed to be, generally? Don't need you to pull out rulers and measure 1 millimeter, 2 millimeters, whatever. Have a general idea of looking at the normals and know what it should look like. Joint spacing comes after joint alignment. I just lump those two together typically. I personally lump them together because as I'm looking for alignment, I'm simultaneously looking at spacing, right? They're kind of the same thing. Surrounding soft tissue. Looking for any foreign bodies or any abnormalities in the surrounding soft tissue. Later on, you'll see how you can use an x-ray when we get a couple of the pictures to show you whether or not this is an open or closed fracture just by looking at the soft tissue. Because you may see a patient and it may have popped out, popped back in, right? And you didn't even notice that they had like a blood mark on their arm when you sent them for x-ray, and that's an open fracture even though it went back in after the injury. And then the area of concern last. Now sometimes you'll notice that area of concern, and you just gotta note it and move on and come back to it at the end, like right here. But if for some reason you know for sure, you're like, hey, they have pain over the ulna. Okay, well, look for that fracture last, so that way you don't get distracted by the shiny new toy. All right? Again, your approach is your approach. It's just gotta have all these categories in it. Here are the definitions of things that we're going to talk about. I've already been using cortical bone or trabecular bone or medullary bone. Those are kind of interchangeable here, right? Your epiphysis, your diaphysis, and your metaphysis. Make sure you know which ones are which, especially when we get the pediatric ones, that's going to be really, really important, right? So the epiphysis is the end part, the diaphysis is the shaft, and the metaphysis is that narrow part in between the two. Alright, it involves a growth plate. We'll talk about that with pediatric stuff. Here's more vocabulary. Gotta know these things. I'm not giving you a vocab quiz. Right? I want to be clear. I am not a factoid guy like, what is a cell that secretes the matrix for bone formation? That's an A&P question. It's not a radiology question. However, if you understand what these things are, then when it comes to trying to understand the disease process, it'll be a lot easier to understand why it looks the way it does on x-ray and help you kind of piece it together. So when we start to get into those ology things, right? Taking different things, putting it together to be able to kind of understand why it's happening the way it is. Osteopetrosis, is basically a hardening of the bone. It becomes denser. May have taken it out this semester, I may not have, we'll see. Osteonecrosis is death of tissue. We will get into osteoporosis, we will get into osteomalacia and osteomyelitis. Osteo is bone, all the different things talking about the different areas, right? Inflammation of the bone marrow, softening of the bones versus fragile, brittle bones for osteoporosis. We'll talk about them in more detail. Everything we're going to cover. Bone composition, bone appearance, bone density. Okay. Almost every lecture will have these fun little anatomy slides on there for you. I'm not going to sit and belabor them. They're there for easy reference. So when you're looking at your anatomy, like when we get into the shoulder, we get into the wrist and everything, you don't have to refer back to your A&P lectures to have the nice little A&P book slides to help you understand one versus the other. Okay? So they're there for you. These are the different parts of the bone that we learned last semester. Moving on. This is like the 4th time we've seen this thing. Might be important. There might be at least 1 or 2 questions on this thing alone. Still haven't written the test, but historically, this might be important. What else on x-ray is the same color as soft tissue? Not muscle. Muscle is soft tissue. So what else? We talked about it briefly. What did you say? Fluid. Fluid and soft tissue, it's not written on here, but fluid and soft tissue are the same color, which is why the heart just looks like one color. It's full of fluid, but it's also got muscle and tissue in it. It's all the same. I cannot distinguish between the two. which again goes back to that CT, right? CT is just a more detailed x-ray, right? It's got that 3D image. That's why the aorta just looks the same. That's why we need contrast to enhance the vessels, to be able to tell the difference between the walls of the vessels or the organs and where the blood or the fluid is, because fluid and soft tissue are the same color on x-ray or CT. Make sense? Okay. What color is bone? Very light gray. What's white? Metal. Okay, moving on. All right. Now I've broken down in slides the different areas of the x-ray of the cortical bone so you can kind of see it a little bit more. I want to draw your attention to the rectangle that's on there that's outlining the cortical bone. More importantly, I want you to see that transition on the inner part of the bone between the cortical bone when it goes into the cancellous or medullary trabecular bone, whatever word you want to use for this course, right? You can see that hard line on the inside where the cortical bone ends and that cancellous medullary bone begins, right? That's your transition point. This is the cortical bone, this more radio-opaque area compared to the center. Any questions on that? So when you're tracing the cortical bone, this is what you're tracing. Looking for any gaps in there. This one doesn't have any. Why? Because you need to see normal a lot before you can pull out the abnormal. This is the medullary bone. Same concept. It should all be the same density. We're still going to trace through all of that area, right? What is that density supposed to be? It's supposed to be uniform, okay? When we get to the osteoporosis, and I can show you those pictures compared to normal, it will stand out at you. You're like, oh, okay, that's lower density. That's more radiolucent, right? But for right now, just know that it should be a uniform density. You shouldn't have any black lines through it or any changes in that medullary bone density for a normal x-ray, okay? Just another view of that cancellous or medullary bone. Obviously, the hip area has more nutrients. It has a different type of cancellous bone in there. So I'm not comparing this part of the bone to the one in that bone, right? Those are two different areas. Those bones have two different purposes. They're going to look different in comparison to one another. But how does this look in comparison with itself, right? Sure. This is all good. This is all healthy. Okay? But you can see your cortical bone. Also see how much thinner the cortex is on this part of the hip here than it is on this guy here, right? It looks a little bit different. I'm not comparing different body parts to one another. All I really care about is there any fracture in any of these areas for right now? So what causes change in bone density, right? Newborn formation is that osteoblast. And we'll see that when we start talking about the healing of fractures and the healing of bone. Reabsorption of older damaged bone is the osteoclast activity. Cancer can cause it. Hormonal changes can cause it, especially when we start talking about osteoporosis in postmenopausal women. Genetics, vitamin D deficiency. I mean, look at all of these things, right? So if like somebody asks you, hey, what causes changes in bone density? Right? And so a lot of times, from just an x-ray, you can't figure out what's causing it, but the x-ray is a lot of times your first indication that something else is going on that you didn't even realize. Because if I have changes in bone density and I don't have a reason for it, now I need to find the reason for it. So it's definitely more than just looking for fractures. All right. So here are some things, the FYIs are topics that I'm not testing you on in this course, but you will see again throughout your IPAP time. So they're in here, we discussed them briefly so you have some exposure to them, but I will not be testing you on the FYI conditions. The other ones are fair game, okay? But put them in there because I promise you, you will see Paget's disease in peds. You will see hyperparathyroidism in endo next semester. You will see osteolytic metastases and multiple myeloma in hemo. And I don't want it to be the first time that you see it image-wise. Okay? So first we're gonna jump into some generalized increase in bone density causes. So we have two of them, diffuse osteoblastic metastases and osteopetrosis. The first one is FYI, go back to this chart. And it even says FYI, right there. Okay? So, diffuse osteoblastic metastases. So now let's think about this, right? Diffuse means everywhere, right? Osteoblastic means I'm doing what? Building it up, creating more, and metastases mean this came from somewhere else. This is a patient with prostate cancer. We have prostate cancer. This is what, so now look, I have my normal x-ray on the left, okay, and my abnormal on the right. And I know you're all sitting there going, listen, I never looked at an x-ray before my entire life, but I can tell you the one on the right is abnormal, right? Great, good, right? That's fine. But I want you to focus more on the normal one that I have here. Because you may be able to tell me that one's abnormal. What happens if it was just one lesion you caught early? Are you going to be able to find it? Maybe not now, but the goal is later on you will be able to, right? This is an extreme case. So these are diffuse osteoblastic metastases. This is what it looks like from a patient who had prostate cancer. And you're right, it is a overabundance and a creation of more calcium and more bone due to the cancers. So what are the big spots here? So all these little circles, right? All these little bright white circles. And the way you would look at it is, let's just focus in on this guy right here, okay? This one right here. How would that stand out? Well, remember when I'm going through my technique and I'm looking at my cancellous or medullary bone, is it all the same density? Or does something stand out at me that looks a little bit different? So if you had just this lesion here, right? The goal is at the end of this course, you'll be able to pull it out and you might not know what it is, right? Because just with that, I have no clue. I don't know what that is. I know it's abnormal, so I just need to know I need to act on it a little bit further, right? So can you just look at this and tell me this diffuse osteoblastic metastases without a patient history? Probably not. You just know that there's something abnormal, right? Radiology is adjunct to other information, which means in your vignettes, there will be important information to help guide you to what you're looking for a lot of these disease processes. Okay. Interesting. Okay. Title of this slide, I'm going to make a note of that. This is the your osteopetrosis. I don't know what happened to my title on that. Oh, it's right there. It just should be bigger. Okay. So this is your osteopetrosis. Okay. It's a genetic disorder, an autosomal recessive genetic disorder. And what happens is the bones harden. They continue to harden. They don't stop, right? This is normal on this side. And what's supposed to happen when we grow is you have your cortical bone, and it starts to harden to be the outside of the bone, and then it stops. And it leaves your medullary bone or your cancellous bone alone. Osteopetrosis, it doesn't stop. The entire bone hardens. Now you would think, hey, that's really good news, right? No, everything has its purpose. When it hardens like this, they are super brittle. Fractures are very, very common, very, very easy to get, okay? And this is going to be one of those generalized density things. So the bones really become sclerotic, they become really thick, which makes them really weak and brittle because the cortical bone keeps everything together, but this medullary and cancellous bone almost acts like that sponge, right? It acts as that shock absorber to kind of help when you jump down off the steps and think, this can't do that. It's all basically cortical bone. And that's why it's so bright, right, diffuse. Anybody know what this is? I don't think I talked about it. That's a lead shield to protect the ovaries. This is a girl, right? You can tell by the soft tissue. This is a female, okay? And so that is actually designed to protect the ovaries from the radiation of the X-ray. So it's a little lead shield that's put on the females. So how would I know that this is osteopetrosis? Well, it's going to be the only condition I'm going to show you that has everything look like this, right? I don't have patient symptoms for you because there really isn't any, because this is an autosomal recessive genetic disorder. Really, the way you end up finding this is you end up having somebody who is having frequent fractures and you're not really sure why. and they come in and you get the x-ray, and usually what ends up happening, this is not the first x-ray you go to. You end up x-raying like the tib fib, right? Where they hurt themselves or whatever. And then the whole thing looks white with a fracture. You're like, what the heck is that? So then you get the whole leg, and then you get both, and then you realize, okay, then you start digging, and maybe you're the first one to find this, but usually they'll end up like some kind of family history of like, oh yeah, my grandma used to have, you know, her bones would like break all the time or something like that. I never really knew what it was called, because again, it's recessive, which means the other challenge is that you could have a person who's neither one of their parents had it, and they just happen to be the bad luck to get both those genes and end up with this condition. So really you would kind of see this as if somebody's getting fractures and they don't realize why they're getting it so often, and you get an x-ray and the entire bone is white like this. Yes, sir?
What age do you start to see the fractures from this?
That varies. There's not a set. It's usually, it's one of the things to what happens is it's usually adulthood. It's not often in peds because the bones are continuing to grow in peds, right? So we haven't gotten that stage yet. So it's adulthood, but again, the speed of how quickly this happens and when the issues are happening, it varies by person. Because men are supposed to stop around 21, women 18 or something along those lines with like the bone growth, and then it just keeps going. Questions on generalized increase in bone density causes? Ooh, there's one that's testable. So you shouldn't be able to sort through the two of them, hopefully, right? All right, so now I'm going to go back for a second here. So now we have the focal increase in bone density. Focal means more narrow, right? Localized area, not diffuse, not everywhere. And I believe, there's only one that's testable on that list, okay? So avascular necrosis. Now I will say, don't brush that off because avascular necrosis can happen in multiple areas and it's super, super important. And we'll cover that throughout the course a couple of times, okay? All right, so first we have diffuse osteoblastic metastases. Now I have local. So first of all, what type of imaging is this? Okay, I heard mumbles of both. All right, so it's a CT. What kind of slice is it? Yeah, this was like 3 months ago, right? Coronal. This is the coronal slice. If I keep asking you the kind of modality and slice it is, it's probably important. So, CT, coronal. Remember, coronal suture, slicing from front to back is my coronal slices. What body part is this? Yeah, pelvis, hips, I'll buy that, okay. Which side of the body is affected, right or left? Oh, you do know. Oh, don't say we don't know. It's their left. Remember, when I have both sides of an X-ray or a CT, it's the opposite of what I'm looking at. So my right is the patient's left. I don't need a marker. You do know, and if you don't know, you need to know. Here's my abnormality, right? I'm going to point that out right here. All right, here's my localized osteoblastic metastases. Let's see if I made a note of what this patient had. We don't know exactly what it was, but definitely, I don't know what type of cancer it was, but this is a sign of metastases from a cancer typically in that aspect, which means if you have a patient who doesn't have a history of cancer and you see this, guess what you're going to do? You're going to start working them up for cancer because they probably have one that they don't know about. Right? Good. This is good for you guys in other courses. You don't need it for mine, but you're going to get to a point when you're going to have to start distinguishing between osteoblastic and osteolytic. Right? I put this in a nice chart for you guys to help realize, and especially in your clinic, which cancers are most common. So when I get this image, and I go, ooh, you don't have a history of cancer? Right? This is an osteoblastic concern. Now I'm going to be more concerned with prostate, breast cancer, lymphoma. Probably not carcinomas because they're rare. So I'm going to start investigating for those first. This is beneficial in your clinic, right? Whereas if you get osteolytic, which we'll talk about in a little bit here, that's when I'm going, okay, maybe lung. Breast obviously can be both, but now I want to look at the thyroid and the kidney as well when I have my lytic lesions. right? This is not a 100% like always type thing. This is a most common when it comes to medicine, right? I don't like to use the words never and always in medicine, because the second you do that, you're going to get the patient that busts the trend, right? Most likely when you see the lesions, this is the cancers you want to start investigating for based off lesion, and this will become handy in your clinic. All right, avascular necrosis, the first testable one that's on here. What happens is we have cellular death leading to the collapse of affected bone. Lots of different causes can cause this, okay? And typically it's areas of the bone that have poor blood supply. Most commonly your scaphoid and your femoral head. These are the two most common locations because of the way the anatomy works. If the blood supply is interrupted, that bone can die, causing avascular necrosis. Why is it avascular? Well, necrosis because it's dying, avascular because you've cut off the blood supply, so it doesn't have vasculature giving blood anymore. That's where the name comes from. Can be asymptomatic. That's the challenge with this. It may not even be causing them any pain, okay? Until it gets worse. X-ray is your initial study. X-ray is your initial study in yellow. If you suspect a scaphoid fracture or a femoral head fracture, you're going to get an X-ray. If the X-ray is negative, you're not done. You will tell them, I need you to come back in 7 to 10 days, or 10 to 14 days, usually it's 7 to 10, if your pain is not resolved, so I can follow up with you. If they show up and their pain is not resolved, you order another X-ray. Sometimes those fractures can lag from injury because of swelling and other reasons. It may not have popped up yet, and now all of a sudden you see an X-ray in the or a fracture in the scaphoid or the femoral head. If it's still negative, follow up in 7 to 10 days if it's not any better. If they come back that third time, you're ordering the MRI. The MRI is your study of choice because at this point you need to make sure that there's not a fracture in there. And although MRI is not necessarily a study of choice to look for fractures, it is to look for avascular necrosis. And so it will pop up. If your MRI is negative, you are safe. That is super sensitive. Okay? Why don't we just jump to MRIs? If it's that sensitive and it works really well, it costs more money, takes forever to get in, and a lot of places don't have them. Almost everywhere has an X-ray. Normal. This little divot here in the femoral head is the fovea, okay? That's normal hip. Compression due to avascular necrosis. There was a fracture somewhere in here. This is, again, fine. There's a fracture somewhere in here. And then it compressed down due to weight bearing. And how do I know that? Well, let me look at this head. Let me look at this one. Oh, that's nice and round. Oh, that's not nice and round. All right, that is not shaped the way your femoral head should be shaped.
With avascular necrosis, if there's like a certain time frame when you should go and actually look at an MRI to see if we're worried about the progression of the necrotic.
So the question here was, with avascular necrosis, is there a certain time frame we should jump straight to the MRI because we're worried about the necrotic bone? In the most cases, I would say no, and here's why. The majority of these patients, if they're having pain, are going to come to you right after the injury, right? This doesn't happen in like a week or two. This doesn't happen in like a week or two over here, all right? This is because somebody missed it and didn't do the appropriate follow-up, which is why that stepwise process of like, hey, the X-ray looks normal, come back in a week if it's not better, and like you tell them, like be honest with your patient, be like, there is a condition, it's rare, it doesn't look like it right now, but there's a condition that we're like, if we miss it, it can cause, your bone to kind of degrade and cause some issues. So really, if you're not better in a week, I need you to come back so I can reevaluate that. Like, make that important to them as well. And as long as you follow that stepwise, you're going to be okay. Now, if somebody comes in and, it's been 6 weeks since the injury and stuff like that, and you order the X-ray and it looks normal and you still follow that process, nobody's going to get on you going, well, it was 6 weeks, why didn't you just jump to the MRI? Because that's not the standard of care. Any other questions? Yeah.
Is that femur starting to like bend because of
Yeah, good eye. So everybody see it right here? So the weight because now the weight is being distributed differently on this patient, the femur, if you look at the cortex, right? That was my next point, so good catch. It's starting to bend and shift from that additional weight. So this is where what you just did is don't get distracted by the shiny new toy. Still go through your stepwise process and see if there are any other abnormalities on the film. Now, we haven't gone over strictly the full anatomy of the femur and the pelvis here in the forms of an x-ray, but that's enough there for you to recognize that, hey, we've got something going on here. And also, look at this here. You see the radial lucency there, right? I don't know what's going on there, but there could be some other injuries or other bone depth going on there as well, because it's definitely more radiolucent than the rest of the surrounding tissue. And even more important, compared to the other side, it's definitely more radiolucent compared to the other side. Does everybody see that? Those are those extra little things that when you go through your stepwise process can help you out and make sure you don't miss. Okay. What happens if you have avascular necrosis on an x-ray that you find, but there was no injury or fracture that you expected? These are different other things that can cause avascular necrosis. STARS is the acronym that I like to use. Steroid use or lupus, systemic lupus erythematous. T for trauma. We're going to talk about all of those trauma things to include SCFE in this course, so you'll have a good understanding of those. Chronic alcoholism, renal failure, rheumatoid arthritis, radiation, and sickle cell disease. Sickle cell disease, not trait, disease. Military seems to have a hard time distinguishing between those two over the past few years. So, put that in your toolbox for patients that could be subject to avascular necrosis even though they didn't have an injury. Now, I will still say, at least for the course for this course, really looking at scaphoid and femoral head, right? Could it happen in other areas? Maybe, but unlikely, because if you impede the blood flow in other areas, guess what? There's other vessels there that are bringing blood. But the scaphoid and the femoral head are the ones that have like those one-way blood flows that if you impede that, that's what causes the avascular necrosis. We will stop there and re-hit the wrist on Friday.